Antiarrhythmic drugs help control arrhythmias or abnormal heartbeats. There are four main groups of antiarrhythmic medications. Class 1, sodium channel blockers. Class 2, beta blockers. Class 3, potassium channel blockers. Class 4, calcium channel blockers. And miscellaneous antiarrhythmics, or unclassified antiarrhythmics. We'll focus on Class 1 antiarrhythmics, which are further broken down into 1A, 1B, and 1C. All three groups work on sodium channels in the cardiac myocytes, so Class 1 medications are also called sodium channel blockers. Normally, an electrical signal starts at the sinoatrial or SA node in the right atrium, then propagates through both atria, making them contract. The signal gets delayed a bit as it goes through the atrioventricular or AV node, then goes through the bundle of His to the Purkinje fibers of both ventricles, making them contract as well. When a heartbeat doesn't follow this path, it's called an arrhythmia, and there are two main causes: abnormal automaticity and abnormal reentry. Abnormal automaticity is when an area of the heart, say a part of the ventricle, begins to fire off action potentials at a rate that's even faster than the SA node. As a result, this area of the heart essentially flips roles with the SA node, firing so fast that the pacemaker cells in the SA node don't get a chance to fire. At that point, the heartbeat is being driven by the ventricles. Alternatively, there can be an abnormal reentry, which often results from scar tissue in a ventricle after a heart attack. Scar tissue doesn't conduct electricity, so the signal just goes around and around the scar, and each cycle can cause the ventricles to contract. Alternatively, there might be an accessory or extra pathway between the atria and the ventricles, like the bundle of Kent in Wolff-Parkinson-White syndrome. Here, the signal might move back up the accessory pathway, since oftentimes it's bidirectional, meaning the signal can go from atrium to ventricle, as well as from ventricle to atrium. This creates a re-entry circuit that causes extra contractions that occur in between the signals coming from the SA node. Now, let's focus on a single action potential in a myocyte. It can be broken into 5 phases. Here's a graph of the membrane potential versus time. In phase 4, which is the resting phase, the myocyte's membrane slowly depolarizes. This is caused by the leakage of some ions, mainly calcium ions, through the gap junctions, which are openings between two neighboring cells, and that makes the membrane depolarize to the threshold potential, which marks the start of phase 0. Phase 0 is the depolarization phase, where voltage-gated sodium channels open up when they reach the threshold potential, and they allow sodium to rush into the cell, creating an inward current. This rapid influx of sodium causes the myocyte's membrane potential to become more positive. After the membrane has depolarized, we enter phase 1, initial repolarization. At this point, the sodium channels close and the voltage-gated potassium channels open up, allowing positive potassium ions to leave the cell. This is called the outward current, and the membrane potential starts to fall, and this creates a little notch on our graph. Soon, there's phase 2, or the plateau phase, which is when the voltage-gated calcium channels open up, and that allows positively charged calcium ions into the cell, which counterbalances the potassium ions that are flowing out, so the membrane potential remains pretty stable. During phase 3, or repolarization, the calcium channels close, but the potassium channels remain open, resulting in a net outward positive current. At the same time, ion pumps start to pump calcium ions back out of the cell, and that causes the heart to relax. Eventually, the myocyte returns to the resting membrane potential, and we start over with phase 4 again. Class 1 antiarrhythmic drugs act on sodium channels, and they're state-dependent, meaning that they bind more tightly to cardiac tissue that's depolarizing a lot. In other words, they are even more effective when an arrhythmia is severe, and are more selective for abnormally overreactive parts of the heart. Class 1A antiarrhythmics inhibit the sodium channels and the potassium channels on atrial and ventricular myocytes and cells of the Purkinje fibers. When sodium channels are blocked, it decreases the amount of sodium entering the cell, so this causes a slower depolarization, which means a decrease in the slope during phase 0. When the potassium channels are blocked, there's less potassium leaving the cell, and it leads to a slower rate of repolarization and a longer phase 1, 2, and 3, which means a longer effective refractory period. On the ECG, this shows up as a longer QRS complex and a longer QT segment. So overall, slower depolarization leads to slower conduction of the action potential throughout the heart, which means a slower heart rate. Now, common drugs in class 1A include quinidine, procainamide, and disopyramide. All three drugs can be used to treat both supraventricular and ventricular arrhythmias, but should be avoided in people with heart failure since they have a negative inotropic effect on the heart and could lead to hypotension. In addition, procainamide is very effective in treating Wolff-Parkinson-White syndrome. Since these drugs prolong the QT, they can trigger a type of arrhythmia called torsade de pointe, which means the twisting of points, because the QRS complexes seem to twist around the isoelectric line. For other side effects, quinidine can cause synchronism, which includes headaches, tinnitus, and blurry vision. Long-term use of procainamide can cause systemic lupus erythematosus. And finally, disopyramide has anticholinergic side effects and could cause hypotension, dry eyes, dry mouth, and urinary retention. Class 1B antiarrhythmic drugs inhibit the sodium channels in Purkinje fiber cells, ventricular myocytes, but not the atrial ones. Common medications used here include mexiletine and lidocaine. They're not as potent in blocking sodium channel activity as Class 1A drugs, so you can see this on the graph that there's a smaller change in the slope in phase 0 as compared to Class 1A. Furthermore, they're more likely to bind to depolarized cells or myocytes damaged by ischemia since they have trouble with maintaining their negative membrane potential. Through an unknown mechanism, these drugs also cause a slight decrease to the refractory period, which leads to a shorter action potential. But this doesn't have much clinical effect. Due to their weak potency and selectiveness for ischemic tissue, Class 1B drugs don't cause changes to the ECG. They are most commonly used for treating ischemic arrhythmias like the ones seen after a myocardial infarction. Lidocaine can also be used to treat digoxin toxicity, but it's also a local anesthetic if used topically. However, lidocaine causes CNS toxicity, which could lead to seizures if used as an antiarrhythmic. Mexiletine, on the other hand, can cause GI symptoms like nausea and vomiting. On to Class 1C drugs. These drugs also inhibit the sodium channels in atrial and ventricular myocytes and Purkinje fiber cells. Common Class 1C medications include flecainide and propafenone. They have the strongest potency out of the three types of Class 1 antiarrhythmics. So on the action potential chart, you can see a dramatic decrease in the slope of phase 0. Class 1C drugs don't have any effect on action potential or effective refractory period. They can cause longer QRS complexes on an ECG, but don't cause long QT intervals. Class 1C drugs can be used for ventricular tachycardia that progress to ventricular fibrillation, but they're typically used for arrhythmias that are refractory or don't respond to other treatments. The reason for this is that while all Class 1 antiarrhythmic drugs can cause arrhythmias, Class 1C drugs are the most likely to do so. This is especially true in people with ischemic heart disease, like right after a myocardial infarction, since it could lead to sudden cardiac death. Another side effect of propafenone is that it causes a bitter or metallic taste. Now, we want to make a simple and fun mnemonic that'll help you efficiently memorize and retain all these pharmacology facts. So, we're going on a road trip, and each stop represents one of the 4 classes of antiarrhythmic medications. Since the sea is full of salt, let's head to the beach for the Class 1 antiarrhythmics, which work on the sodium channels. So, the first thing we see is 3 buoys in the sea with the labels 1A, 1B, and 1C. This represents the 3 areas where we'll put our 3 groups of Class 1 antiarrhythmics. So, on the beach, in front of the 1A buoy, there's a pyramid with a large disco ball on top for disopyramide. An Egyptian queen representing quinidine is standing outside. There's also a large porcelain wolf statue guarding the pyramids for procainamide. For side effects, the disco music is giving the queen tinnitus and a headache, while the disco lights are giving her blurry vision. Next, disopyramide has anticholinergic side effects like decreased lacrimation, salivation, and urinary retention, so let's put a dried up skull sticking out of the sand by the pyramid. Procainamide can cause lupus erythematosus with prolonged use, so let's have a lonely red wolf sniffing the proclined, or leaning forward, wolf statue. Now, remember, procainamide is very effective in treating Wolff-Parkinson-White syndrome, so let's have a white wolf also sniffing the statue. Okay, let's move forward to the 1B boy. Here on the beach, we have a trash can lid for lidocaine, and there's a Mexican taco on top for mexiletine. To help you remember lidocaine can be used to treat digoxin toxicity, let's have an ox with a shovel digging next to the trash can lid, searching for the rest of the can perhaps. Let's stick a rotting brain in the hole since one of the side effects of lidocaine is CNS toxicity. Mexiletine causes GI distress, and it makes sense if you're eating tacos off garbage can lids. Let's move on to the third boy labeled 1C. So on this stretch of the beach, there's a flea-ridden canine for flecainide, and it's chewing on a propane tank for propafenone. Propane tanks are metallic, which will help you remember that one of the side effects of propafenone is a metallic taste. Okay, to help you remember the potency of these medications, there's a large wave washing over the 1C boy, a small wave for 1B, and a medium-sized wave for 1A. The size of these waves correlate to the potency of each group of the Class 1 antiarrhythmics. Finally, only Class 1A drugs cause a long QT syndrome, so let's use a squirrel with a long tail who's quite a cutie to represent the long QT interval. It's standing on the 1A boy holding a rhythmic gymnastics ribbon that looks like the ECG reading for torsade de pointe. Alright, as a quick recap. Class 1 antiarrhythmic drugs are also known as sodium channel blockers. They slow down the influx of sodium during phase 0 of the action potential in myocytes and slows conduction of the action potential. Class 1A drugs have moderate potency and cause a wide QRS complex and a long QT interval that results in a longer action potential. Class 1B drugs are the weakest and cause shorter action potentials and has no effect on ECG. Class 1C drugs are the strongest and don't change the action potential but result in a wide QRS complex. But wait, there's more. Here's a mind map with all of the mnemonics. Go ahead and pause the video so you can test yourself to see what you remember. Stay tuned for the answers after the credits.